Okay, everybody, we're going to get started. So as you all know, we've been to many doctor's visits. And the one thing that we all have to endure is a lot of questions from the doctors. And so now we get to give them some of their own medicine. So we are going to ask them as many questions as we can. But first, I want them each to introduce themselves. I appreciate all of them being here to help us today. Thank you.
Hi, I'm Marcio Sotero. I am interested in AHC for a while, and I am specialized in epilepsy in children.
Hi, I'm Nutan Sharma, and I'm a movement disorder neurologist with a focus in dystonia.
I'm Terry Sanger. I'm a child neurologist, movement disorders as well for children, and I run the deep brain stimulation program at Children's Hospital Orange County.
Kathy Swoboda. I'm a neurologist and clinical geneticist, and I've been interested in studying and learning more about AHC for 25 plus years now.
And I'm Kenneth Silver, pediatric neurologist. I'm several years older than Kathy Swoboda and working with AHC for 35 years.
Hi, I'm Sho Yano, pediatric neurologist and clinical geneticist. Do a lot of ATP1A3 research, but I'm learning from these people.
Okay. Okay, so the fun is now going to begin. We have some questions that were submitted in advance of the meeting. So we're going to try to get to as many of those as possible. We have questions coming in online, and we have questions in the room. So we're going to try to rotate through those as quickly as we can to get as many questions answered as possible. And sometimes our questions are multi-layered and need to be addressed in length outside of the room. So if we have to move along to the next question, please feel free to corner someone after the meeting, but we do want to try to get as many questions answered today as possible. So here goes. The first question is, should we start seeing a movement disorder specialist before my child starts walking? Movement disorder specialist.
I think you see a movement disorder specialist as soon as you have a movement disorder. We can, there's certainly when the diagnosis is made, sometimes it can be helpful, but I think at that point, it's really the geneticists and the metabolism people, movement disorder specialists treat symptoms.
I agree.
Yeah.
And we're going to go online.
Can you scan that down? All right, this is one of those very tough questions. What are the benefits, risks of intubation, extubation for status seizure and or status dystonia? How long is too long to wait before intervention with propofol? Well, a lot of questions on this one. What is the best way to approach this with ICU doctors? Written plan.
So you intubate a person when they're not breathing very well. That's the right time. So if somebody hasn't responded to the first treatment for prolonged seizures, you add a different agent. And throughout that, we'll be monitoring how well the patient is breathing, how's the oxygen in the bloodstream, and get some blood gas to see the carbon dioxide. There's some way of checking that in the skin too. And but it gets to a point that when the person doesn't have good reflexes for breathing, that happens. Now, for movement disorders, when we have patients who have both, you kind of have to monitor about the same thing. If you're desperate and the patient's having some problems with that, that's what you do. As far as using propofol, there's a sequence of medications that we use for seizures, especially. So we usually start with a benzodiazepine like diazepam, lorazepam, all those PAMs usually, and they all have a similar mechanism. And then we give a second medication, usually something like phosphonitidine or Keppra, levetiracetam. And then by the second or third medication, people start thinking about protecting the airway, especially if the reflexes are not good, and start thinking about something in the class of general anesthetics. Propofol is one of them. The other ones are sevoflurane, those halogenated. They're a little bit harder because they are better than in the operating room. But they have a few options, and propofol is just one of those options. Propofol is a little harder in kids because it's hard to maintain for a long time because the blood acid can increase. So a lot of the times people do not use propofol long term, like you use in a 25-year-old. Usually you don't use that for a 2-year-old for a long term.
One of the things that I think people often get wrong in the ICU setting is that they'll be too slow. Status dystonicus is an emergency. And if you get behind and you sort of wait and say, let's wait and see what happens, I'll give this drug, let's wait and see what happens. So I usually really advocate to be extremely aggressive, stop it, whatever you have to do. I agree, you intubate when you need to intubate, but you also say you're willing to intubate. Intubation is nothing compared to allowing the status dystonicus to continue. So it's often very hard to convince people to be as aggressive as they need to be in these cases.
Yeah, I would just add for status dystonicus, it's better to intubate so that you're then freer to aggressively treat the dystonia, because the medicines that we use also make people sleepy, and then we're worried that they can't control their airway. So it's better to control the airway before we start really aggressively pushing the medicine.
In epilepsy, we always say the magic number is 3 drugs. 2, you should start thinking. 3, you should definitely be having the tube in a hand. Do you have like something like that?
No, I think unfortunately, because in dystonia, we don't have as many choices of drugs, right? So I would say secondly, but certainly by the second drug, you should really be thinking. And it's always better to do it in a controlled setting before it is an emergency.
One question that came in advance is, some adults are experiencing head tremors that seem more like Parkinson's. Are you seeing more patients with Parkinson's type symptoms? And can you have both AHC and rapid onset Parkinsonism?
Okay, so first, so there are many different types of tremor, and believe it or not, movement disorder neurologists will go to meetings and review videos and get into arguments over how to classify these tremors. So just because someone has a head tremor does not mean it's a Parkinson's-like tremor. Certainly, as kids who have AHC get older, so there are a couple of things. So a head tremor in and of itself, without a tremor in an arm or leg at rest, is not Parkinson's. It's a different kind of tremor. Those tremors, if they're bothersome, can be controlled, can be reduced with some medications, or actually with Botox as kids get older and can handle injections. The advantage of using Botox is it's not another medicine that goes through the entire body. Was there any? I think I answered. Yes, so they can have some features of AHC and RDP, but I would not call a head tremor Parkinsonian. You can also just get dystonia of the neck and have a tremor associated with it.
And a question from the audience? I know you got them. Come on, don't be shy. All right.
Okay, my son is 33 and all he really has right now is the dystonia. He does take Artane 3 times a day. I think it's 200 milligrams each dose. And then his first rescue is lorazepam. And the second one is diazepam. The Artane took away almost totally the dystonia of the mouth. I hardly ever see that anymore. Gone. He does have the eye. He says his eye bounces. I feel it. I can feel the bouncing. That's probably done 75%, but it really hasn't done anything with the hand or the leg. So are there other medications out there? And this is coming from his movement neurologist.
We have very little for dystonia. Artane is one, benzodiazepines, the problem is dystonia comes in two flavors. It comes in the hyperkinetic form and the hypertonic form. And usually, so you can either be stiff, you can have too much movement. Most people have a combination of those. Artane works for the stiffness. It makes the hyperkinetic worse. Benzodiazepines work for the hyperkinetic ones and can make you sleepy. We just don't have that much else. Some kids are their use of dopaminergic drugs will help, but that's a case-by-case basis. So that's using levodopa and dopamine agonists, depending on what you think the problem is. And then beyond that, it's deep brain stimulation and baclofen pumps. There's not much, and watching the doses carefully is very important. Drugs like Artane have there's a wide range of possible doses, but there's usually a right dose for somebody, and so trying to get that adjusted can be difficult.
I think that was pretty comprehensive, but I will say I recently met an adult who we diagnosed very late that had incredible success with paroxysmal worsening of the pain, in dystonia in a generalized fashion with IM Benadryl, which his old-fashioned pediatrician began using, and he's used it for 25 years and it works beautifully. That's sort of more invasive, and the oral Benadryl doesn't work very well, makes you sleepy. But if they're in acute pain and they're having pain all the time or whatever, I started to use that as a backup option to consider.
Jump online and take a question from there, and then we'll get back to the audience.
This is my daughter's senses, touch, smell, noise, taste are more sensitive as she's gotten older. Are there any other AHC adults like that?
Do you want to repeat the question?
Yeah.
Can you
repeat again? Sorry, it's my daughter's senses, touch, smell, noise, taste are more sensitive. Are there other adults that are like that? It happens as she's gotten older.
I'm not aware anybody studied that. We do know those sensory stimulations are important in triggering attacks of hemiplegia, hemidystonia. It wouldn't be surprising that this occurs, but I don't think we've actually looked at that so much in older patients.
I would say sometimes the movement disorder does change as patients get older. And so what might have seemed to be a less severe dystonia might be a more dramatic dystonia as they get older, or maybe they had hemiplegia and not a painful dystonia. So it could have the appearance, yes, that they're more sensitive, but I think it is actually has to do with the underlying nervous system problems that are related to AHC and not necessarily a change in the senses per se or the sensitivity, but they are more sensitive to triggers if they're in some cases when they get older with regard to the dystonia. I've certainly seen that. That does happen.
We'll go to the audience. Oh, go ahead.
Thank you. Hi, thank you. Are there any other options for rescue meds for dystonia if my son is suffering side effects of agitation post-use?
Is it from the Valium? It's from the Valium. So sometimes we also use clonidine. I don't know if he's on that medicine. And the advantage is that works on a different receptor in the brain. So hopefully, at least I like to think that if we attack different receptors, we'll get a better response.
Yeah, the typical rescue medications really are just the benzodiazepines. I do usually recommend that people use as little of them as possible at baseline so that they're more effective as rescue. So the problem is that there's a real tendency kid will be in trouble. The doses go up, they're discharged from the hospital on the high doses. Now they're still on the high doses, they habituate to that. And now you don't have the ability to use them anymore because they're habituated. You have to really try to come down as much as you can. I'm a big fan of using clonazepam when children are going through things that could be potential triggers. It's a longer acting benzodiazepine. So a child who, for instance, is triggered by a viral illness or by some kind of other metabolic issue, maybe changes in diet or something, using clonazepam to bridge kids through can be helpful. But when they're getting into crisis, you need rapid acting things. Generally, Ativan or Valium would be typical. There's and I do agree, there are people who've even used intrathecal, so spinal tap injections of clonidine as rescue in these cases, and a few reports of that being effective. I don't believe that's been tested in AHC.
I do think that intranasal Versed, sometimes you can switch the benzos, and one, like Terry said, Dr. Sanger said, one might be more likely to induce post dosage agitation than the other. And, intranasal Versed acts quickly, but it also wears off quickly. So sometimes you can use it in combination with something that's going to kick in a little bit later, in my experience. But you do have to be really careful, as Dr. Sanger said, to not suppress respiration in that case.
So I really like clonazepam as well to use that acutely, because some of the attacks are not just a few minutes. Sometimes they go on for hours or days. And I like clonazepam, which gives a better, longer duration, and both for acute attacks as well as chronically, if patients are having frequent dystonic attacks, just to continue on a regular dosing of clonazepam. A few patients have tried extra doses of their baclofen, which seem to help. And the other treatments often for dystonia are like Cinemets, L-Dopa combinations, as well as the Artane to maintain things under control. But clonazepam for an acute exacerbation, extra dose or so seems often to help.
Related question that came in advance is, can frequent or daily use of midazolam as a rescue drug for AHC episodes cause memory loss?
Yes.
Let's leave it there. We'll go to the audience for a question and then online next.
So we didn't know what we were experiencing with our son, but he would go completely, he would look to be unconscious, and we could wake him up and he could say a sentence or two, but his whole body is affected. We take him to our local ER. We're in a rural part of Colorado, and we'll take him to the local emergency room, and they'll literally just stare at our child, or they'll put him in PICU, and they'll do no intervention on him. They'll do no medication, no intubation, nothing. They'll literally keep him there for a week, then ask me if I'm comfortable going home, send us to hospice, and send us home every time. And then he wakes up and we've had no treatment. So besides finding a better hospital, what point should we be pushing as parents for them to intubate him or treat him? Because we feel like it's causing him to regress. He's having these full body episodes, and he's coming out of it with 6 to 12 months of physical regression from therapies and stuff, and they're not really doing anything for our child. So I was just wondering if you have any suggestions for us on what tests we should push for, because we just sound like the crazy parents, but I mean, my kid's suffering in the end.
Some advice. I mean, you could discuss with your neurologist to have a protocol. Like we do that with several rare diseases. People have like a printed protocol from the neurologist that treats you. If it's obviously if it's a dystonic episode, you heard, there's not a protocol. And if you have like plegic, like just a weak episode, you use something. That's the thing that you I'm sorry. It's a him, right? It's a boy? Yeah. And when you're a neurologist to discuss, have a type protocol and say, this is Dr. such and such's note, which is like an action items, like do this, do that, do that. If this happens, do this. If the limbs are stiff, there's dystonia, you do that. That's the fix for that. And usually people feel more comfortable, especially if there is a line to reach for the person.
I think I missed part of that, but you said he's unresponsive or he's just not physically able to move, but he's awake. Because I got the impression he's not like in unresponsive state mentally. But they do EEG? Yeah. Well, they need to do you have to prove that before you decide that, right? I mean, there are rare patients, and I discovered this very early on when we were doing this, that can have coma-like episodes with ATP1A3 mutations where they will literally go into a coma, be flaccid. The EEG doesn't show seizure, and then they wake up and they do have some memory loss and encephalopathy. That is a phenotype. It's you know, it is hard to know exactly what the best thing to do to manage that is, whether you should sedate them or not. I think I don't know if others have thoughts about that. I think my bias is to sedate them to try to get them out of the episode and support them. But how long do you do that? And what should the protocol be? I'd love to hear some of my colleagues think about that.
You have a seizure in that situation. I thought he was awake, but not being able to move. If he's not awake, it's a general rule of pediatric neurology, pediatric epilepsy. Somebody who is not aware, not moving, you do an EEG and you prove 1 for every 4 or for every 3 will have seizure. Known fact. But if you made the point, the first patient that I had with alternating hemiplegia when I came to Seattle Children's Hospital presented like that. They had several episodes. To complicate, sometimes there were seizures, sometimes there were not. And then you just have to be very diligent to do that. Should also be in the protocol. Most places will do EEG because in our professional organization, the American Clinical Neurophysiology Society, it has guidelines for that. And that people who are trained in EEG all read those. But yeah, and you should have at least the 3 main options. You're having a seizure, do that. You're not having a seizure just weak, do that, which is make him sleep. And he's having dystonia, and we have our team here to give you counseling, but usually it's pretty similar. We end up giving medications that are not that different.
One of the, the recurrence of the episodes, of course, is one of the horrible things about this disease, but it does give you an opportunity to try different things on different ones. And if something works, that becomes part of your protocol. And often the first line, which sounds counterintuitive, is if you have a kid who's unresponsive, you give them high doses of benzodiazepines. Sounds wrong. You're giving a sedative to a non-responsive kid, but you're basically trying to abort the episode.
Okay, we're going to go online next.
Is nystagmus considered a type of dystonia? Are there medications that help with nystagmus? My daughter is 1.5 years and her nystagmus seems to bother her a lot during episodes.
Come on, you want to.
I don't think of nystagmus as being a component, but abnormal eye movements of many forms are associated with cerebellar abnormalities. There is some concern that the cerebellum may be strongly affected in AHC. And so it's not impossible, whether it's a feature of the episode or whether it's a feature of the progression of the disease. I don't know. It's very hard to treat. And, if it's an episodic phenomenon, then the treatment would be the same as with any AHC episode. But if it's baseline, it's quite hard to treat nystagmus and can interfere with vision significantly.
I think that she implied, whoever was asking the question here, she implied that it was intermittent though, right? So I would assume it was with an episode which most of the time that intermittent nystagmus, you would treat it as an episode, even if you don't see other components happening, especially if it's bothering her.
Audience?
And we have an adult daughter who's 22, and the Movement Disorder Clinic has suggested that we should start thinking about DBS. And I'm wondering if it's been used effectively with an ATP1A3 AHC diagnosis, or is it just too early? Like, I have a hard reaction to say no, but I want to know if anyone's had any success, or should we be considering this? Because right now I'm very adverse to it.
You know, I'm not aware that anybody has done DBS in an AHC case yet. That doesn't mean it hasn't been done. Not everyone reports their cases. They particularly don't report them when they don't work. So that doesn't mean that people haven't tried, but I'm just not aware of it. I do have to say, one of the things that I and some of the other centers have started doing is a technique where we put temporary wires into kids with diseases when we don't know what the target is or whether it will work, and we just try it for a week or so in the hospital and see what happens. It's a little scarier in diseases like AHC, where you could trigger an episode by doing something like that. So I think there's, you know, it's elective brain surgery. So the benefits have to outweigh the risk significantly. But I think if you had a child who was just, you'd really have no other options, and particularly if the child is in pain or is rapidly deteriorating with the episodes, that would be a situation where you'd think, okay, we really don't have any options, and might be worth the risk.
So I just want to add that for ATP1A3 mutations that result in rapid onset dystonia Parkinsonism, there have been anecdotal reports that it is not beneficial. Right? And as a general rule of thumb, I always tell all my patients, you should never rush to neurosurgery, right? So you have to really think about it. There is and for good reason, we evaluate people slowly over time. There's, you know, so that you can get all your questions answered. A team evaluates, you know, your daughter. So I would keep it in mind, but not rush. Yeah.
We just had, Dr. Sang and I just had a long discussion about this. I am much more optimistic that DBS will be helpful in some of these patients. I think that they will have to we will have to choose very carefully which patients. I think the patients who could benefit would be those somewhat older patients who really have refractory frequent dystonia that is painful and disabling. And, you know, again, I remember the miracle of seeing the first patients treated with TOR1A mutations. That was such a horrific condition. And it's made a huge difference to have DBS for that. And many of the teenage, you know, patients that I've had with very severe painful dystonia that's very frequent remind me a lot of what we used to see with torsion, what used to be called idiopathic torsion dystonia. No longer idiopathic, I guess, because we know what it is. But I think it is something that should never, you know, it should really be in the context of what has the family tried, really have they exhausted all the other therapies that could be tried? Do we think the window has closed for new therapies coming forward that might be a genetic therapy or in any sense oligo in the future? But I remain really optimistic that some patients could benefit from what I know about what we see in the brain in these patients. So that's my thought.
Yeah, sorry. So, and I just want to add, so our experience, if you look at all dystonias, all forms of dystonia, so there's one specific region of the brain that is currently the FDA approved site, right? And our experience is that the best benefit is kind of from the neck down to kind of mid calf, right? kind of, it's more the center of the body, right? So if someone has a particularly painful dystonic hand or foot, that honestly is better treated with injections of botulinum toxin. And so let's say that someone has DBS and we've improved their trunk and their legs, right? The DBS helps. It's not going to make everything perfect, right? And so then you have to think about other things for the more, for the hands and the feet, what can be of help. There's something else.
I think Kenneth wanted to make a point. This is very
a counterpoint. So although I don't do DBS, I mean, I have a few patients previously, but I thought about DBS in some of my really intractable dystonic AHC patients. And so certainly for idiopathic, the so-called idiopathic dystonia syndrome, those kids do improve dramatically. I've had other patients who are neurodegenerative disorders, and it does improve somewhat. But some of the specific gene identified disorders, some it does help, some it doesn't help. And certainly with the RDP, where we have the same gene being affected, causing the rapid onset dystonia syndrome, I would be hesitant to offer that with patients with AHC because we're talking about the same gene and pathophysiology of the disorder.
Counterpoint again.
Yeah. Well, I think it's worth being, there's what we do sort of standard. And one of the things you'd mentioned is there's sort of a standard. I'm not sure anything is FDA approved for anything other than primary dystonia, but the standard target is the internal globus pallidus. What we found is in children with disorders other than that, there's many other targets. Dystonia can come from many different parts of the brain, and it's likely in AHC it's coming from more than one part of the brain. And so I think we need to distinguish between deep brain stimulation as it is commonly done and deep brain stimulation as it needs to be done in the sense that the brain is a big place, and we need to have better ways of targeting.
One more thing I just want to add that. So let's say, someone gets DBS, they don't think it's helping. Well, we can just turn the battery off and leave it there. So as far as I know, it also doesn't preclude other treatment should they come down the pike. So that's important.
Yeah, and I would like to see the detailed studies because there's none published that I have seen in the literature about DBS for RDP. Are you aware of any? Posters at meetings. Stay tuned. Stay tuned.
Okay, here's one from earlier. Can anyone speak about oxygen therapy? What is it? And do we know if it works? Oxygen therapy?
Yes. Okay. So fascinating. And I think there was a European physician who started doing oxygen therapy on patients, and very limited publication. It just seemed to be an article in a newspaper. That's all I could find. And do no harm. That's the first dictum in medicine, is do no harm. All drugs are poisons. Oxygen, we all need oxygen to survive, but 21%, we get more of it. It's a drug. It's not just a natural treatment. And hyperoxemia can damage the lungs. We know from newborns who need continuous high dose oxygen, it damages their lungs, it damages their eyes. This happens in older patients as well. It stimulates what's called reactive oxygen species, and these cause over inflammation and inflammatory markers, and could go through different areas, including the brain, to cause additional damage. So does oxygen therapy work? It might not. It has to be studied in a placebo-controlled fashion. and mostly to monitor for toxic side effects. And everybody's vulnerable. These children would be also extremely vulnerable. And so I think one has to proceed cautiously under controlled environment where patients probably should be studied. What is the oxygen level in the blood? What is the oxygen level in the brain? That there's ways to measure that and monitor their lung function, their pulmonary vital capacities and things like that, which are easily measured to make sure that no damage is being done by this drug treatment.
We're gonna go to the back of the room. We have a question, and then we'll go online after this question. Oh, did you have an oxygen therapy? Oh, we'll get to her later.
Hi, everyone. We have a question around medication. So Maria's 11 years old. She's been on Topamax and Phenobarb since she was around 3. So she's growing now, and we're looking at something more long-term. Her current neurologist is looking into possibly flunarizine, which was suggested to us years ago, but there was a supply issue at the time. And the advice was, don't start her on anything that we can't consistently sustain, that you can't just take her off of it. But it seems now that there might be an option towards medication, getting that as an alternative source. So I wanted to find out, one, what the advice is on moving to flunarizine, and whether you had any thoughts around doses that we could start with, and also whether we should be looking at, we haven't ever done anything for her around dystonia. She only tends to have it when she's having really bad episodes, like those longer ones where it's a full body episode. So it'll be dystonia from like the neck and the rest of the body. And those, as she's grown older, seem to be painful. They didn't when she was younger. She now does seem to show that she's uncomfortable. Should we be looking for a home-based solution, like an emergency thing that I can do, that I can give her to end that episode in the instance that we don't need to go into hospital? Because we haven't needed to go to hospital for all of them. It's for when her airway has been blocked and we then see that she's in distress, that we then rush her to hospital. Thank you.
That's kind of a two-part question. Do you want to address the flunarizine part first?
Well, I'll talk about the topiramate. Yes, topiramate does decrease a little bit your speech output. When the topiramate was first marketed in the United States, there was a guy in England who had topiramate for a little bit longer, who had adults with that, and decreases speech output. So it's not just overall sedating only. Topiramate does decrease that, and he used fancier measures of speech output that you can only do in adults, kind of making lists of animals start with letter A or something like that. The question about flunarizine was, should you start? Flunarizine has been shown to decrease some of the events in alternating hemiplegia. Is always a consideration. It's probably the medication that we use the most. Overall, kind of half of the patients show some response. The studies are not great. We are the first one. We've been discussing all this meeting, all of us, about how the studies were, none of them are great. And they use measures which are not super precise, but it probably improves. All of us have several patients who had more or less good response, and we'll tell you that it helps. I have not been very impressed, and I will ask the movement disorder people, with preventing uncomfortable dystonia episodes with that. So maybe I'll pass the microphone to the left here. Have you had good results with decreasing those painful episodes of dystonia? That's the question.
With the flunarizine, I have not. So for that, I tend to use the diazepam or clonazepam, the other method. And then the question is, how frequently do you need to use it? Because it's, it's, as Dr. Sanger was saying, not good to use, frequently. And then we have to think about, does someone need daily medicines to try to help lower the odds that those episodes will happen.
The evidence for all of the idea of, so to separate it sort of the baseline medicines, can you prevent or reduce the frequency or severity of the episodes? And then what do you do when an episode happens? So preventing or reducing frequency, flunarizine is typically used for that, whether the data supporting that are fairly weak. That said, I put all my kids on flunarizine. Just because I feel like it doesn't, I am one of those people, yes. But you have to titrate the dose. High doses can definitely have side effects, and we have to be very careful about it. Does it definitely work? I don't know. I'm too scared to take the kids off of it. So now other things have been recommended because you're dealing with channels that affect sodium and potassium. People have considered things like Diamox or Topamax as possible preventives. I've seen kids where it seems to make them better, and I've seen kids where Diamox seems to make them worse, and in one case actually triggered an episode. So there have been recommendations of using things like memantine and ketamine. Depending again on the particular mutation, the gene involved. So I think it's all, we don't know the answer to that. In terms of rescue, as I was saying before, I think your benzodiazepines are the primary ones, both the fast acting and slow acting ones that are concerned. Again, as I said before, you want to keep those at baseline as low as you possibly can, so that you have them available as a rescue, just because tolerance builds up.
I think flunarizine just needs further evaluation, period. We have data from the very first trial that was done by Kenneth Silver, Dr. Silver, and the data in some patients, it does seem to work immediately in the first 3 months. It seems like you see something, but then when they've been on it 5, 6, 10 years, I don't know. What is it still working as a prophylactic? What is it doing? Is it protecting them? Is it neuroprotective in some way? Makati has made that argument, and there was some data that I thought was weak, but there in the mouse model that it treated epilepsy. It's not an anticonvulsant. It's not an effective anticonvulsant, but did the mice live longer because it was neuroprotective in some way? We just don't know. So I will, until the day I die, continue pushing for a proper trial. And I am so tired of everybody going on flunarizine without good data being collected. So please, if your doctor is going to put you on flunarizine, do Stephen Henderson's new app, which is now available for 12 weeks before, get yourself on a dose and continue it for 12 weeks after. Thank you for your support.
Counterpoint. I stand by my research. I think that flunarizine is an excellent drug, low toxicity, and it certainly diminishes the duration of attacks. We've seen patients who previously had attacks for hours or days, and now they're diminished to minutes. The frequency did not improve as much. Long term, I'm less impressed with the flunarizine helping dystonia. I think dystonia evolves as the children get into their adolescence and early adulthood. And I think that the flunarizine is not as helpful, but I think it maintains benefit for hemiplegic attacks. These were uncontrolled, non-placebo controlled studies, and you're all biased. You want to see something better. So it is a scientific deficiency that we don't have those good placebo-controlled studies. And we've tried over the years as physicians to do that, but it's become very cumbersome. So I think we have to deal with what we got and try to tweak the science of the flunarizine to see it helps. And I agree with clonazepam for the dystonic episodes. I think there's sublingual clonazepam. I don't know if it's available to you. And we talked about, is flunarizine available in Europe? Because it's been used there initially for over 50 years. I think that might be a good source if you're not sure about the North American Canadian reliability of obtaining it.
I just want to say, I spoke very firmly, but I just want to get data. Just that's all I want is data. Data. We need data.
Oh, we're gonna go online real fast and then we'll come back to the room.
Okay, just because I've never seen this question before, I'm going to ask it to Dr. Yano. My son is 5 years old and he presented with hypothyroidism after the 3 most severe episodes with seizures. Is this a common thing with AHC children or has it been seen in other kids? The first time he took medication for hypothyroidism for 2 months. The second time it resolved without medication. And the third, his endocrinologist is evaluating the need for medication.
It's a really great question, and I'll ask the experts here to stop me if they've seen hypothyroidism in AHC. So maybe Dr. Swoboda will want to answer this as well, but this could make sense because this sodium potassium pump that we know is the cause of problems in AHC also has a function in the thyroid. As far as I know, the pump that's working in the thyroid gland is a different form of this enzyme though. And we have seen that people with mutations in that gene will have hypothyroidism. For AHC specifically, I'm not really sure how that would be connected to what's going on in the brain during an acute event, but maybe Dr. Swoboda wants to speak to that part.
There's a thing called sick euthyroid syndrome, where when patients get really ill and you check thyroid hormones, they're temporarily screwed up. This is a very common phenomenon. We see it in ICU patients all the time. So if you don't want to see it and you're not going to treat it, please don't check it.
Okay, we're gonna run to the back of the room for a minute, or we'll stop here. Did you have a question?
My question is more about when we talk about rescue meds, they come in different varieties, right? We have rescue meds that come in nasal form, and Nasalam now is in those preloaded things that pop into the nose. We get no luck with those, but it's the same drug as the one that we pull from a vial and put an atomizer on the end of the syringe. We get a lot of luck with that. We also get a lot of luck with rectal Valium. Now, when we talk about rescues, and I know in our community where, well, I use that for rescue. I use that for rescue, and that didn't work for me. But I think the form kind of matters. I didn't know if you guys could speak to at least what I understand is the same drug delivered in different ways, and the variability on their effectiveness.
If you're talking about midazolam, the nasal, the one that you buy commercially and comes with a little squirt thing, you go, psst, that thing has a fixed dose. That's the first thing that you have to know. It's only 5 milligrams. And the person or the company who wanted to do that wanted to get that fixed so that you can get easy to administrate, but it's a little inconvenient because midazolam is dosed by 0.2 milligrams per kilogram of body weight. So he already makes it a little stiff for us instead of the more gradual increment that you do with the nasal syringe that you have to draw and all that. Having said that, once my wife had a patient, she's a teacher. She had a patient with epilepsy in the school. It was like a war to convince people just to poke the vial with a needle and draw it. And people go like, what do we do with that? And people, and you have to write in the prescription, take the needle off before you put in the nose, because otherwise people just don't know what to do with that, because we just use the needle and the people get a little nervous until somebody comes and say, oh, my dad has diabetes. I'm used to do that. And they know exactly what to do. It's a little more inconvenient and take a little bit more time, but once you get trained, it's good because the dose is a little better adjust. So you can do, instead of just either 5 or 10, which you do with a pre-adjusted one, you can do 7.5. That may be the dose for your kid. Midazolam is very convenient pharmacologically because when it goes in the nose drains to the heart, to the jugular vein, and then goes down to the heart and goes boom, right to the brain. And that's kind of what we want, kind of fast. There are other drugs. You can give nasal diazepam that's commercially available. You can do rectal, which is pretty decent, absorb pretty fast. The one thing that we talked before about benzodiazepines, this drug, the PAMs, you should always use, if your doctor puts you in a maintenance, that's great, stick with that. And if you don't, try to save one that's going to be your rescue drug. There is good evidence that your body, in rats and animals, that you can measure that. When your body sees this drug, diazepam or lorazepam, all the PAMs, it kind of gets used, the receptors for that drug called the GABA receptors, they change a little bit over time. So it's nice to stick with one. And when that one loses efficacy, talk with your doctor about switching. That's usually rule. But other than that, we do trial and error a little bit. Sometimes this one makes you go cuckoo and the other one doesn't. Like lorazepam, I think 1 out of every 5 patients I use, they go a little crazy. But we do have that reaction with some other ones. So you have to discuss that. But if you use that little bit harder one that you have to draw, you're going to keep a dose that's a little bit better. And my experience with alternating hemiplegias is sometimes the patients end up needing a dose that's a little bit higher than the recommended one for you to respond. And that's what you do before you switch doses, switch drugs.
I would just say that your experience that the route of administration matters. We see this for many drugs. And it's very different between different children. You've got 30,000 other genes in your body that are regulating how your intestines, the mucosal lining of your nose, your absorption of different medications by different routes. So a lot of this is you just have to try. In every kid, we see this in epilepsy all the time. The same drug given by a different route will have completely different efficacy.
We're going to run to the back of the room again, and then we'll go online next.
Yeah, so the question I have is really about like other tools in the toolbox, because like our 3-year-old Aubrey, often she'll have a great run. She'll go 3 to 4 weeks with like really solid stretch. If episodes happen, they're short-lived, minimal impact, but then inevitably you get, the big one hits and it's multiple days and it's severe. She's fully paralyzed, can't move, has waves of dystonia, and in sometimes those cases we give her lorazepam and at bedtime melatonin, try these things, but it just seems to have minimal or no effect. So we consider that like we've got to weather the storm, I guess. And like what other things might have therapeutic benefit? Like I'm wondering about I don't know, for dystonia, for example, is there like massages you can do? Does it things like taking them out for bike rides or kids things that sort of keeps their brain distracted? I don't know, like I'm just wondering what other things we could try that aren't like pharmaceutical or rescue medicine.
Okay.
I would say there's something unique, I think, about AHC in that, there are movement disorders that have triggers that you also can find tricks to make better. And, one of the things that I've watched these older kids learn how to try to get themselves out of episodes. They can learn certain strategies. They sort of know one's coming sometimes and they'll remove themselves from the stimulation, or they'll go into a swing, or they'll do these things like that. And a lot of times when we are having a status dystonicus, what I learned sometimes is that the more we messed with the kid, the worse it got and the more extremis. And sometimes if you back away, and just soothe them, you can sort of reverse what's happening. Now, for these really long episodes that go on for days, that's less effective. But when that's happening, removing them from stimulation, trying to find things to distract them, I do think it has an impact.
Yeah, I don't, I'm not the expert in the fundamental biomechanisms of this, but I'll tell you my experience from the clinical side of this is that once an episode starts, you want to stop it as quickly as you can. The pumps are doing their best and they're failing, and the cells are filling up with sodium and presumably calcium at the same time. It takes a while to pump all that stuff out. The kid has to rest, ideally sleep. And that's the only way that you're going to stop this. If you can't calm them down, if you can't get rid of the stimulus, and the stimulus again could be something. It could be lack of sleep the night before. It could have been a virus. There's lots of things that can do this, and of course, it can be emotional stressors. If you can't stop that, then you have to go very rapidly for high doses of medicines. I don't think you have much of a choice to abort these things. But if you could get it early and you can stop them early before they have completely depleted this and the cells go into this sort of very, very bad electrolyte state, then you may be able to stop something in between. But otherwise, you have to rest. As every time the cell fires, sodium's going in, potassium's going out, pump's not working. It's just going to build up over time. You got to stop the cells from firing.
So I just wanted to add, so for dystonia, regardless of the cause, you have to be a massage with any pressure can actually worsen the dystonia itself. So lightly stroking her to help her rest and feel less anxious is fine, but I would advise not doing anything more physically.
So right from the beginning, when this syndrome was first described and continues now with about 70% of the patients asleep, which is a treatment for attacks. Unfortunately, inducing sleep doesn't work with every child or with every attack. Melatonin, there's controversy about giving it to children, but I think we rely a lot on melatonin to try to get them to sleep, sometimes in combination with clonazepam. Sometimes it works, sometimes it doesn't. If you're available, breastfeeding and puts the children to sleep, they're very comfortable and they wake up attack-free. So these are things. Other natural treatments, I'm not aware of anything that's really worked. Children are, especially babies, are often irritable. They stay awake, and the minute you take them for a car ride, it puts them to sleep. So that might be something you can try.
I'm going to read a question for the next one. I have 2 kids with a clinical diagnosis of AHC. They have had whole exome sequencing done twice, and their question is 2-part. Is it worthwhile doing whole genome sequencing since the whole exome sequencing was negative for both kids? And the second part is there a link between CSF pressure and AHC?
Right. So for the first part of this question, a part of it actually depends on when the whole exome sequencing was done. The technology for this has been advancing, and we have also been getting more information about genes that can be associated with HC and HC-like phenotypes, as we heard earlier with things like Claudin-5. So if the exome was done more than 2 or so years ago, it would be definitely worth having that re-reviewed. So a medical geneticist or the genetic testing laboratory can often do that. So they would go back through the sequence data that was obtained and see if any of the new information helps them say, oh, this looks more promising as the cause of the symptoms, or maybe this thing that came up on the testing report before actually isn't related. Whole genome sequencing does have a better diagnostic rate than exome sequencing. Actually, this mostly is because, not because the genome, we find mutations in introns or parts of the DNA that aren't on the exome. It's just because the sequencing is better, because the number of reads of the sequence that they get is larger. And so they're more likely to find a mutation that might have gotten missed on the exome. Of course, this comes with more cost considerations, but there is a small but real benefit where you can find things that fell through the cracks on the exome.
I think that's pretty complete. I think just the case that was the scenario of like Claudin 5, for instance, that wasn't known to be associated with HC until very recently. There are also several other newly reported associations with HC, and also HC has some variability, and there are other disorders that should be excluded, in rare cases that are mimics of HC. So to make sure that you go back and think, did we do a full metabolic workup for mitochondrial disease? What about the imaging? Is there anything unusual about the imaging? Have they looked for moya disease or something unusual? I think, and then when often they'll do these reanalyses for free, but if they don't, you still may be able to justify redoing the testing if enough time has passed.
There was a quick second part of that question is there a link between high CSF pressure and AHC? Okay. Well, no comment is the answer.
No, I will say that I used to do spinal taps on all these kids, but I was much more focused on looking at metabolic testing and other things. I rarely, when a kid is in a dystonic spell or when they're in anxiety, or unless you sedate them, and even it screws up the pressure testing is the bottom line. It's hard to get accurate data. I'm not aware. I don't know if any of you are aware of any, but that's the challenge is I have no question that they have high pressure in their CSF when they're in the midst of a dystonic crisis. There's no question about that. But does that cause relevant long-term issues? Maybe it does affect the blood-brain barrier. Maybe there are some other things that we don't fully understand, but we don't know. No. You think no, the answer is no. It's not related. Okay.
We're going to go online, then we'll go back to the room in a minute.
Do AHC patients have status seizure and dystonia at the same time? Does one spread into the other, or is it more likely something else could be provoking factor for both seizure and dystonia?
Yeah. Well, I don't know about the etiology. Most likely, I would say yes, because those things have this similar trigger sometimes. I had a patient who had both, one after the other after the one. So I would say yes for that, like a very firm yes, as opposed to the firm no on the previous one. But yeah, I'm not sure I understand that we understand exactly the pathological trigger. Exactly, I would say the usual hypoglycemia, general metabolic unwellness, viral infections and all that really happened, then you should be paying attention when somebody who was just having dystonic posturing and starts twitching rhythmically and looking to the side. I think the most sneaky things that we miss is just not noticing that the movement changed and that the person that was awake and is not completely aware. Having said that, people with alternating hemiplegia has also bouts of being weak or dystonic and a little bit on la land. They are not all seizures. So sometimes that's a not very nice answer, not very easy answer, but sometimes you just have to kind of work them up. If you're not sure, take them to the emergency room and they may need an EEG.
I don't, the mechanisms of both seizures and dystonia are not all that well understood. I tend to think of seizures as starting from a cellular level instability and progressing and spreading, and they can therefore spread anywhere. Whereas dystonia is much more of sort of a network instability in the sense that different areas of the brain are sort of interconnected in ways, and therefore dystonia doesn't seem to spread. If you have dystonia in your arm, it doesn't make you pass out ever, right? But a seizure that starts in your arm could make you pass out because it can spread in different ways. That said, AHC is a cellular level abnormality, and it tends to, over time, causes the cells to be less excitable, but is triggered by high activity, probably. So I would think that there's probably a subset of kids who have seizures, and the seizure is triggering the AHC. Right? It's trying to make a cell fire, and the cell can't after a while. And there's a phenomenon in seizures referred to as Todd's paralysis, whereas after a seizure's been going on for a while, the cells stop being able to fire, and then you get weak for about a half hour afterwards. That's probably a different mechanism, but it's the same general concept that too much activity can cause after effects of too little activity. And it's probable that in AHC, anything that causes too much activity can end up having those after effects, which can have to have a duration of hours or days.
I would say it's not so important sometimes to know if they're having both if you're treating the acute episode, but it is important for long-term management, because there are different prophylactic drugs you're going to think about if it's a true epileptic locus, right? And that's particularly, there are some mutations in the gene that are more prone to be associated with development of refractory epilepsy, including the, E815K mutation. So I have a different threshold for different kids, but I will say during my training, I am not an epileptologist, but I certainly have spent time around a lot of different epileptologists. And sometimes I really, having my training in Boston, going through different epileptic monitoring units around the city, it's quite interesting because Beth Israel Hospital in Boston routinely stuck depth electrodes in. And I saw the most strange and unusual things that looked like dystonia, that looked like panic attacks, that looked like, anything you can imagine. And they were related to very deep-seated seizures that weren't being picked up on the surface electrodes. And so sometimes the phenomenology could be changing subtly. They can be developing an epileptic focus over time. And the same patient that was repeatedly presenting with status dystonicus all of a sudden does show up with status epilepticus. And this happened recently with one of my patients that has been in Boston for years, So I think that we always have to have an open mind about considering what's going on, take another look, get another EEG. Unfortunately, I know you guys hate it, but we need them because we need.
That is number one. There's a cumulative yield of EEGs for everybody with epilepsy. So the first EEG, it's not as good as the second. It flattens at about 4. But people with alternating hemiplegia, if you're not sure, especially it's a disease that you have more seizures later on in the course of the disease, you may have negative EEGs 20 if you do all of them in the first 2 years of life, and then later they'll become more positive. And nowadays, for example, here in California, there are several institutions who have those fast deployment EEGs that you just put there in the emergency room. You don't need an epileptologist. You have like a little computerized interpretation, some screening tests. You could do that and go back to your neurologist, repeat a long-term EEG if you're not sure. So repeating the EEG is always the way to go if you're not sure, because it can be challenging.
I will go to the back of the room. I think someone had a question back here. Do we still have a question? Okay.
Hi. So my son, maybe in January, his episodes looked more like he would have them for 3 to 5 days in a row. And then he would have maybe about a week of a good week with maybe a couple here peppered in throughout the week, and then another 3-5 days in a row. And now I guess maybe in March or May-ish, he's been getting the 3 to 5 day episodes every week. And then those days between, he might have one good day and then a really short episode. So my question is, the only difference other than maybe there's the evolution of his episodes are happening is that we've been giving him probiotic yogurt to help with constipation. I don't know if there's any, from patients or research, if there's any correlation between either probiotic supplements or probiotic yogurt that would have a connection with increasing or even decreasing episodes. But yeah, thank you.
The only thing I would say, as I've followed, lots more and more patients over the years, there clearly is a relationship between when patients get constipated and the likelihood and what causes that. Is it that the brain, it is their neurotransmitters in the gut, like sensing something and they're slowing down? What is it? Which comes first? Probiotic, I have no experience with, but treating the constipation aggressively works in some kids who are having an exacerbation of their spells. They're constipated, and if you help clean them out. I have also had the experience with some adults where they have such severe constipation that we didn't realize they had, because they have a very high pain threshold, and they come in completely they need clean out in the ER. And that was the cause. So these kids, I think bad sensory input of any sort can aggravate. And you just have to think, what's going on? Is there something going on with their belly? Is there something going on in their ear that we don't know about? What could be underlying this? And just make sure because they can't always tell us, or they often won't tell us.
I would actually ask the panelists the question. I mean, we're dealing with a disorder of sodium and potassium. And so you can affect your serum sodium and potassium significantly by what you eat and how your intestines are processing that stuff. And it's been raised as a question, how much diet could have an effect on triggering this. So you can imagine these cells are trying very hard to pump sodium and potassium uphill. And so do you have an effect on the steepness of that hill based on what the blood concentrations are? And I don't know the answer. It's something we've hypothesized.
I think there was a published study with extra dosing in the diet of potassium. And I think they reported that the children improved, but really was not very consistent. So we certainly wouldn't advocate high dose potassium. There's risks for that, side effects. And, could you flood the system? I think extracellular brain potassium is not good for you. So I don't think that's something that I would recommend. One of the burgeoning interests in literature, I mean, we talked about this, is that there's a gut-brain connection, and there's now scientists and people who, that's all they do is they study the connection of bacterial flora in the gut. We have billions of bacteria. You don't want to think about it, but inside our guts are billions and billions of bacteria. All of them are different. All of them are have specific purposes, and depending on the flora in your gut affects your brain function as well to some degree. And I'm just thinking that when you started the probiotics, did that change the gut flora? And that's changing the mechanism. We have a biochemist. I don't know if he's involved at all in any gut neurophysiology and neurotransmitters that are secreted in the brain, in the gut, and how does that affect the brain?
So I just want to take a step back and say one thing, and then I would like Al George to comment. He alluded to this in his talk, but sodium and potassium are very tightly regulated, and you really have to screw up the diet a lot and have a ton of extra, too much of things or too little of things for the body, because it's deadly, right? If you raise your potassium level, you're going to have a cardiac arrhythmia. That being said, there are disorders out there like hyperkalemic periodic paralysis where, there is potential some relationship with fluctuations in serum potassium and dietary influences. This gene is not one of them, to my knowledge. I don't think we have any data to support that there's any intrinsic, effect of alternating the diet, sodium or potassium in your diet. The only time I've seen the electrolyte screwed up, and it does happen on a regular basis in these patients. What happens is they get sick. They don't eat for long periods of time very well because they're in 9 days of episodes, and you can get a water deficit. You can get, if you have a G tube and you're removing fluid and you're not doing, you can screw up the electrolytes. And I have seen it happen. But I think that's a reflection of the episode itself and not, and the dietary, but I could be completely wrong. But I wish Al would comment on, is there any reason to think that the sodium potassium ATPase is sensitive to dietary changes in sodium or potassium?
Yeah, no, I think this comes up all the time because we can't control very much. We can change what we eat, and we can eat more salt or less salt, or more potassium or less potassium. My bias is it's probably irrelevant, because under normal physiological conditions, what we eat every day is balanced, but by what we pee out every day. And there are these two big juicy organs that sit near our backs called the kidneys that are controlling that. And so our bodies are very resilient to wide swings in dietary intake of sodium. Take, for example, you can go on an extraordinarily low sodium diet for weeks. Your blood sodium doesn't change. Then you suddenly start going to McDonald's 3 times a day, and you have a massive sodium intake. Your serum sodium doesn't change. Kidneys are very resilient and control all that. Potassium is the same thing. And I do think that Kathy pointed out very wisely that too much potassium can be bad for you. Again, your kidneys, if working properly, should adjust for that. Regarding the sodium potassium ATPase, importantly, this is an active transport pump. It's working on energy. It doesn't depend on the gradient of sodium or potassium. So it doesn't matter to the pump. It's going to just keep moving whatever's available. And I don't think it really matters. And I think dietary intake of sodium or potassium, except in the extremes, is probably irrelevant.
Okay. Oh, okay. Hold on a second. Thank you for the heads up.
This is much a question. I'm not offering expertise, other than to mention that ATP1A3 is expressed in the colon, and that may be some local regulatory phenomenon may be affected in the patients. So you should probably talk to a gastroenterologist who might know a drug that would stimulate motility. If you can stimulate motility, that will fix the constipation problem.
Question in the back of the room. Bill, can we go back here and then up to you? Can you hold on a second? Okay. All right. Pipe down, Bill. I'm coming. There you go.
So that was the medical side of it, but the worst, my son, who's 21 now, I don't know how old your son or daughter is, was constipation. So whether the gut doesn't talk to the brain doesn't talk to the gut, or he has low tone and can't pass food through, whatever it is, he was at his worst when he was constipated. We use melatonin to clear him out. But I'll tell you, when he was not melatonin, Marilax. We gave him anything they had over the counter we could give him. But anyways, and we cleaned him out as fast as well, because he was really, really bad for years. As he's grown up, I will say, he's 21 now. He has no problem going to the bathroom or whatever you feed him. So.
Okay, back to the room. And I'll take this moment for a public service announcement to the people watching at home. I will say hello, Emma. She's screaming at the screen. So shout out to Chicago.
Dr. Sotero, Dr. Sanger, you both mentioned about both a baseline use of clonazepam and a maintenance dose of clonazepam. It sounds like from the clinician side, there's a standard baseline use of clonazepam that's in place. I wonder because from the community of parents, I'm not sure that we've heard that there is that option available. For Annabelle, the use of clonazepam as a prophylactic has been really powerful in dealing with the symptoms. And I wonder if you can comment for the parents in the room on whether or not that's an option that's standard.
Well, what I'd say is that it probably does have some prophylactic value, and using it at baseline probably is effective the same way it would be in epilepsy, but use the lowest possible dose you can get away with, because the more you use at baseline, the less effective it's going to be when an episode starts.
Just to rephrase, there's nothing standard about AHC patients. So a lot of these things have not been studied in a laboratory and clinical trials. So a lot of it is trial and error with an individual patient. So it's doctor's personal experience. They might be correct, they might not be correct, and we try on the basis of the individual child to see how they respond. And yes, lowest dose possible, that's effective. So with clonazepam, we use the lowest dose possible. And then when they're in a bad, prolonged attack, up the dose transiently, and then try to get back down to the low maintenance dose as soon as possible.
So I've used clonazepam and clobazam. Now clobazam is hard to do because the insurance carriers tend not to pay for it unless the patient has Lennox-Gastaut diagnosis. Clobazam is a little less sedating, but the same thing applies with the clonazepam. Use a lower dose. And there's one thing, just going back to the diet. A diet that works sometimes is ketogenic diet in the various forms. Ketogenic diet, Atkins diet, MCT diet. Ketogenic diet makes you constipated. MCT diet makes you go. So you can regulate. That has been used. Some families are not super excited because it is a lot of work and all that. Patients on G-tube, on the other hand, tends to be rather easy to do.
Just someone did comment that they give their child magnesium twice a day to help with constipation. That was a comment. Is there any research about the use of Precedex when coming off vent with AHC? I think our young adult had issues with it.
So I think Dr. McCarty group looked at anesthetic risks with the AHC population, and they found a considerable number of patients, and we know about the cardiac conduction and cardiac abnormalities. I generally, and I think probably my colleagues also, screen patients before they have to go into any kind of surgery. We have them assessed by cardiologists. When it's a new diagnosis, advise them to see cardiology to get a baseline exam. And sometimes the cardiologists want to see them back every year or two, or certainly if there's any symptoms. There's risks with anesthesia. So one should be pre-screened before you have a sedated MRI or any kind of surgery that requires anesthesia.
I know the context of that question, so I'm just going to say the context of that question was more and more in the ICU to prevent agitation. They're putting patients on a medication, IV Precedex, which is very unique sedating agent, that causes a lot of rebound anxiety when you're trying to come off of it. And that patient was in for status epilepticus, and I personally have tried to avoid new medications like that I don't have experience. So I'm interested to hear what Marcio has to say, Dr. Sotero.
Yeah, our ICU, they use a lot of Precedex. That's kind of the go-to medication for them for sedation, because we don't like to give propofol for a long time. So a lot of the patients for MRI sedated autistic patient that needs some sedation for lead placement, they give a little bit of propofol and then switch to Precedex. Precedex is sort of like the IV form of clonidine, the other medication. So it binds to the alpha receptor, alpha adrenergic receptor, that has a lot of central nervous system effect. And EEGers like Precedex because it's one of the few drugs that when you look in the EEG, it looks like you were sleeping. It doesn't look like propofol changes the EEG completely. You look at it and you say, Jesus, what is this? And Precedex looks like you're sleeping. You're going night-night. But, you know, there's a few rebound problems. Most of the times we've been able to go around them by being gentle going down. But again, people with conduction abnormalities, both clonidine actually and Precedex have had problems. And the big deal study that produced problems with the people, not alternating hemiplegia, but patients with attention deficit disorder, there was some increased mortality that was associated by the co-medication of medications for ADD together with clonidine, which is sometimes used for people who are a little hyperactive. So we just a little more careful with that, like you guys said.
Different ICUs will be more or less excited about the use of Precedex. My experience has been in just dystonia in general that it is not useful. It is not helpful in dystonia. You can put somebody to sleep, and as soon as they come off of it, the dystonia is right there. We don't understand the mechanisms of most of these anesthetics, but Precedex probably essentially puts you into something like sleep, but it is not a general inhibitor of brain activity. So that while your brain may go to sleep, the excess activity that was causing the dystonia in the first place isn't being knocked down in any useful way. I would be much more interested in looking at high-dose ketamine as an alternative, because that turns off cells. But again, in general, we just go to high-dose benzodiazepines, and that means IV midazolam and hitting that really hard, and that's a very good anesthetic, and that is effective against dystonia.
And they both also
That's great. That's really valuable for me to hear, because I have had that impression. And this is a patient that has terrible dystonia. And I really wanted to make sure they were treating that effectively. And it really prolonged, I suspect this prolonged her hospital stay, but I can't prove that. I don't know. And we need more data on this. So again, collecting this kind of is really important.
I'm the first one. Ketamine, the Precedex comes out of people not having alternating hemiplegia, having autism most of the times and nothing else, and trying to find something to keep them sedated on and off throughout the day. That's a little bit more or less benign. But the slick thing to do is medication that will hit him, will sedate him, get rid of the dystonia. And since 50% of these people have seizures, you need to use something that's anti-seizure too. Otherwise, you may fix one and get the other. And so midazolam is the best. Midazolam drip is super cool, easy, takes a long time to depress your respiration. And ketamine is also slick because it's of those drugs, the only one that's a little activating, doesn't drop your blood pressure. So epileptologists love when the intensivist is comfortable with ketamine because it doesn't dump down your blood pressure. You never get an answer from them and say, hey, dude, your patient is having seizures. Can you increase something? And they say, no, the blood pressure is too low. So we like that. So I like that. I like that.
I love seeing this debate, and that's actually kind of the point of my question. I think this has been such a productive session to, promote all this discussion between such experts with so much experience, and give the patient community such a great opportunity to pose various questions. I think one thing that has struck me, two things that have struck me, is a variability in effective treatments across different patients and the variability of opinions amongst the experts. And I think it's absolutely terrific that, we're having this very open conversation. And I think treating patient families as, partners and adults capable of, being involved in the discussion, I think is super. I do wonder what your kind of practical advice to patients families would be when they need to be, they're in, an emergent situation where they need to make decisions with other healthcare providers that are not necessarily experts like you are. How can they ask questions? How can they promote their child's well-being in the most kind of effective way, given the kind of variability of solutions and opinions about the solutions? It's really great to have this conversation, but how can we?
One of the things that we heard from a different family is that often people unfamiliar with this and other rare disorders will do nothing. And there's a statement in medicine, which we are all taught, says, first do no harm. And I think it's important to remind the people taking care of your children that doing nothing can do harm. And so the statement, first do no harm, also applies to, if you don't know what you're doing, find somebody who does. And we don't necessarily know what we're doing. And you're right. We need the data. I recall someone to my left saying, get the data. The data are going to be different across the community and in individual children. You have to keep track of what happened with your own child as best you can. Everybody's different. People have the different genes, and genes unrelated to AHC will probably affect its response to different medications. So you have to assume that what's going on with your child is just with your child. But I think you have to be very aggressive with this. I think that there's a tendency to say, okay, the episode's going to resolve in 2 or 3 days. Let's just wait. My personal feeling is that's probably wrong. That these episodes cause damage, and that you want to be as aggressive as you can. Now, that doesn't mean that you can stop them. You can't always do it, but I think you got to be trying, and you have to find teams of people who are willing to intervene, whatever it is, and just keep trying and seeing what works for your kid.
On a practical level, I think one thing that we all are trained as physicians to respond to is data. So if you come into the emergency room and you say, look, my child has this condition, this is what has happened, and you pull out your documents, this is how frequently they occur, this is what has helped in the past. The more hard data you have with you, I think the more receptive, especially like, let's say you're on vacation somewhere and you're dealing with a team that doesn't know you at all. That really helps.
I just want to say that one thing I've learned over the years is that, the ICU is a very special place. There's a lot of emergencies happening. People are more and more burdened, and you have to be protective of your child. Every time you go to the ICU, it's valuable to debrief with your neurologist and make updates to their emergency plan. What worked, what didn't? Why do we think that might be the case? Because the worst thing you can do as a parent, and it's very upsetting to the ICU doctors, they have certain protocols they're really comfortable with. And I know Precedex in the adult ICU is something they're using all the time at certain hospitals. And especially if you've got a child with intellectual disability and autism, that's what they want to use. And they think they have the data that is the best thing. It may or may not be. And maybe they don't regularly use IV midazolam protocols anymore. So you have to sort of take that approach of being aware and engaging them without being confrontational and asking them to call every other doctor on the planet, because that will not work. You have to have a plan and a discussion ahead of time, and there's going to be new stuff that comes up all the time. So that's going to be a very important part of this.
So for those of you who have epilepsy, the epilepsy community for the past decade plus have been using a seizure action plan. Probably most of you have that. That's what we need for alternating hemiplegia of childhood. So you have this written statement. This is what my child has. This is the medications. This was when the last episode was. These are the drugs that he's on and what works. And to have that available on your phone or in your back pocket and show it to the physicians, because they are, especially in the emergency room, they've never heard of AHC unless you bring the child back several times to the same emergency room. And you probably won't, because you said, I took them there, they didn't know anything about it, and they did nothing. So then you look for another emergency room. And the odds are that a general physician would know anything about AHC is unlikely, even pediatric neurologists. Chances are that they've ever seen a case is like, when I calculated this initially, it was 40 years in practice before you saw a case of alternating hemiplegia of childhood. So you need that documentation, and it can't be a book because they don't have the time for it. It would be too overwhelming for them. So it has to be like a brief statement. And unfortunately, we don't have that cheat sheet for alternating hemiplegia of childhood. We've published some little blurbs about it. It's available online. And I think we had a international meeting, was in around a task force about 2015. I think we published what to do. How do you treat status dystonicus? How do you treat patients in an acute attack with the respiratory difficulties? And so that's been published. I haven't seen anything new to change that, but maybe we have to minimize it to a 1 or 2 page summary, so at least they have a framework to work with when they present acutely.
And I would say the one problem that happens often is if you might have, we did create, for some of our patients, a dystonia action plan. But if the dystonia action plan patient hadn't had seizures, but now they come in with status epilepticus, there isn't a seizure action plan yet. But there should be, if you think they're at risk, there should be, if you think this is seizure, it should be part of the plan. And we should think about having rescue medications early in patients we think are at higher risk of developing seizure at some point. So. No, okay.
And I'll just add that this has been on a to-do list for a very long time, is to get action plans or care plans for the AHC community. And this is just the right time where the foundation has been talking about putting the action plans together. We have now a family support committee and the research committee that are able to come together and work on those. So that is something that our medical advisory board and the foundation are going to be moving forward. So can't guarantee when those will be completed, but we do want them to have credibility with like our medical advisory board's names on it, so that if you do go to an emergency room, the physicians, attending the emergency room will know this is a credible document that's been approved by professionals, and at least it's something. So stay tuned, and that'll be coming soon. So we'll go to the room real fast, and then we'll go back to the board.
My son has a shrinking cerebellum on MRI, and it's been slowly shrinking since he was 4, and it's led to behavioral changes and inability to walk as efficiently as he could. And I was wondering if any of that was related to AHC.
Yes. So there are people with AHC who have no changes in the brain over a period of years, and there are people who do have changes in the cerebellum, atrophy or shrinking size, exactly like you said. I don't know if Dr. Swoboda, do you want to say anything about that?
I would say, yeah, I mean, I think that we need to understand this, whether particular mutations, we think some are more likely than others to lead to this phenotype, but some of it's age-related progression, probably of loss of some of the cells in the cerebellum. There are other regions of the brain that can be affected on MRI over time, like you can get temporal sclerosis. You can see changes in the volume if you have really bad epilepsy. Oh, interesting. Yeah, Dr. Sotero says, and I did not know this, that you can get cerebellar atrophy from recurrent status epilepticus. So, I think there's a lot we have to learn. And part of the issue why we don't know more right now is that, often what are we going to do with the MRI imaging so patients don't get follow-up MRIs over time? I think, you know, as we go forward with biomarkers and natural history trials, I'm hoping that we can get correlative regular imaging data at some point. If it's not indicated clinically and we're not going to do anything about it, insurance may not approve it. And so we really have to try to get those on a regular basis. If we think there's an indication that it's progression on the neurologic exam, we have great justification for saying, okay, what's going on? There's something new here. The patient has a gait abnormality. And that's probably why you were able to get serial progression. But there's a lot we have to learn about this.
I think also from a clinical point of view, we can blame a lot more on the cerebellum than we typically do. So the cerebellum is thought to be the part of your brain that controls coordination. And so when it shrinks, you think you will get uncoordinated, and you do. That can give gait instability and problems moving your arms, speech, eye movement abnormalities. But the other thing is that the cerebellum connects to all sorts of delicate portions of the brain. So it has the ability to not just give you not enough, it has the ability to give you too much. And if the wrong part of the cerebellum degenerates, particularly the inhibitory parts, it probably has a lot of excess outputs, which causes dystonia. So the cerebellum probably can cause dystonia, chorea, ataxia, and it's involved in cognitive function. It's involved in language learning. It's involved with the production of speech after you've learned language. So it has many different functions, all of which can be affected in varying combinations. So I think as we've looked at other disorders where the cerebellum degenerates, we become very aware that what it does when it's functioning is not all that closely related to what goes wrong when it's not.
So it's known for a long time that patients with AHC do develop chronic neurological deficits, progressive with ataxia or unstable gait and chorioathetosis. These are two features that have been noted to develop over time. Doesn't seem to be directly related to how bad their AHC symptoms of hemiplegia are or epilepsy. I think it's a natural progression of the gene disorder, and it's highly expressed in the cerebellar Purkinje cells, so that makes it vulnerable. There's two studies that I know of that looked at serial MRIs of AHC patients. In one of them, it showed no change over time, and the other one, it showed different areas of cerebral and cerebellar atrophy. So I'm not sure, I didn't read the studies in depth to see why one study gives different results than the other, but that's the state of the evidence.
We have about 10 minutes left, so we're going to go online for another question.
This question, I feel like I could answer myself, but I'll put it to the professionals. My son has episodes, but not seizures, as far as we know. We do not have a rescue med and have never taken him to the ED for an episode. At what point, symptoms-wise, do we plan to go to ED? His episodes affect him not so. Okay, his episodes affect him not so, not affect. I'm reading what she wrote, okay? His episodes affect him not so, not affect breathing, but he has weakness, pain, dystonia, and strange eye movements during episodes.
I think that's a good question. It's a judgment call. If they have fever, infection, so you want to identify, is that something that's triggering the episode and has to be treated? If it interferes with breathing, respiration, and that has to be supported. If they have quadriplegia and can't swallow for a period of time, we don't want them to get dehydrated. So they might need other means to rehydrate, which IV might be necessary. So you have to go to the ER for that. If there's concern about breathing, that's particularly serious. I've had patients who undergo these marked exacerbations lasting for days, and they go to the ER and they don't do anything. And now they just treat the child at home and they don't want to bother going to the ER because they don't do anything and there's costs involved. And so they just watch a child at home, which is scary for me as a clinician, but that's their choice.
I mean, emergency rooms have tremendous abilities and in this domain have very little knowledge. And so I think what we're hearing is having an action plan is going to be important. So it's not, the question shouldn't be, when do I go to the ER? The question should be, how do I create a plan with knowledgeable clinicians who can tell the ER what to do? I mean, if you go to ER at most hospitals with a neurologic problem, they'll call the neurologist on call, who probably also doesn't know anything about AHC. And they'll phone in, 45 minutes later, they'll come down and they'll, do a little bit of reading. And if they're lucky, they'll know somebody they can call. And by the next day, maybe something's happening. That's not the best way to do this stuff, but it's, this is a rare disorder and you can't blame them. They're dealing with common disorders and that's what they're there for. So just recognize that it's about, you're responsible to bring your own knowledge to the ED in these cases. Otherwise, you're just not going to get rapid treatment. It's not going to be appropriate.
I have to leave because I have to catch a plane. So I'm going to say something very unpopular here and then leave you guys. So everybody's going to have their emergency plan and whatever. When that fails, you have to seek help. I know everybody hates to be in the emergency room waiting forever, but you need to have a plan. It has to be in writing, like we said. But I know I feel bad because of taking some of my family members to the ER and you wait forever, but you have to have a plan. And when that fails, you have to get, because the evidence that we have is that those huge long episodes of hemiplegia or dystonia, they're not as benign as we think. We should at least try to do something. And the something should be something that makes you sleep. That we're just talking about some, this is a good model that we should have. Like if that doesn't work, somebody has to come up with something that makes you sleep, hopefully with some benzodiazepine or some drug like that. And with that, I'll leave. And then I'll leave because I can't play.
We can get it in. Okay, thank you very much for your time, Dr. Sotero. Wait, Dr. George had a question. And we're going to try to fit in Dr. George's questions, so hold on one moment.
And of course, my question is more of a reflective comment about things that have been discussed. And unfortunately, Kathy is leaving the room, which is part of it was hoping to get her reaction. But, heard a lot about the fact that we need more data. And, the fact that there is no standard evidence for efficacy of drugs like flunarizine that are widely used, or a myriad of other drugs that are widely used, is, opens a vacuum for anecdotal stories of, hey, my kid responded to oxygen, my kid responded to cannabidiol or cannabis or 20 other things. We don't do controlled trials on rare diseases, and the reason for that is no one wants to be in the placebo group, right? I mean, I don't think we need to answer the audience, but everyone's nodding. I don't want to be in the placebo group. I want the treatment. But in reality, we need some kind of strategy to do trials in this rare disease. And so I would love for anybody to offer their wisdom about how we do that. And is there something beyond anecdotal evidence that we need to gather, and how to do that with the community's engagement? I don't want to be on a placebo. How do we do that?
I'm throwing this back to you. High oxygen content in the cell cultures of cells, and monitor the response in vitro, and electrical physiology to see if there's any benefit, any difference on the cell. I mean, that's how we all start with all experiments, doing the single cell in a petri dish, then animal experiments and clinical trials, open label for a few patients, and then start placebo-controlled studies. And some are, like 2 to 1 or 3 to 1 treatments versus placebo. So at least you have a better chance of obtaining the actual drug treatment. But the numbers are so small. The problem is with flunarizine that most patients are already on it. So you cannot take them off with a placebo control study. We're always worried about regression and worsening of attacks when you discontinue the flunarizine. And some families even have refused to take flunarizine because they couldn't guarantee the supply and didn't want to take a risk of their children worsening if they started the medicine and had to take it off. So I think there's some other ways we have to study the benefits of flunarizine without withdrawing it and putting them in a placebo-controlled study. Another option, I guess, would be to treat new patients, newly diagnosed, and using that group as placebo and treated group. But I suspect most patients would not want to sit around and wait 6 months or a year or two for results to come out that says that it is benefit over placebo.
And I think it's worth remembering about flunarizine in particular. The reason we use it is back before anybody knew what this disease was, people thought it was a migraine variant. And certain migraine diseases respond to calcium channel blockers, and that's why the whole thing started. The fact that it seems to work may be just our wishful thinking, or it could be that there's some other mechanism involved. It could be that there's a blood vessel response that is similar to migraines, which is being treated by this. But it does suggest that there's an additional mechanism, right? Flunarizine is not thought to be active, I believe, at the sodium potassium pumps. So that there are, that doesn't mean it doesn't work. But the point is, it does illustrate that trying to infer the success of drugs from understanding fundamental mechanisms of disease is itself very fraught when you're dealing with humans. We're very used to being able to cure cancer in rats and being unable to cure the same cancer in humans, right? There a lot of these things. That doesn't mean that you don't use the laboratory science. So when you're dealing with rare diseases, you're more reliant on laboratory science and less reliant on empirical science because you just don't have the numbers necessary to get statistical significance. But the laboratory science has its weaknesses when translated from the animals in the petri dish into humans. The other thing but the other side of this is that when you have small numbers of patients in a clinical trial, you need large effect sizes. So the challenge to the scientific community and the challenge to the parents is to try to say, where are the large effect sizes? If you had something that could stop your child's episodes, you don't need to do a clinical trial of 100 kids. You do a trial in 5, right? Or you do a trial in 1. I forget, I think there's a quote that from, I think it was Ramachandran says, if you have a talking pig, you only need 1, right? If you can fix the disease, right? You can, but the point is there's this trade-off, and this becomes very, very important for rare disorders. So the answer is the continued search for things with large effect sizes. Is what you have to do in the rare disorders, and designs of trials that are crossovers in the same child, the parent observations, maintaining the data on your own child, looking for the whole exome and whole genome sequencing to look for modifier genes as best you can. I'm trying to make the predictions as best we can for these things.
I think the hardest thing for me as a clinician with flunarizine, I have no question that it works in some individuals because I have seen, very dramatic effects. I don't know if that was just an initial effect. I don't know how long it lasts, and I don't know how to adjust the dose over time. I don't know what the levels are, and I don't know what the mechanism is. But I don't know most of that stuff about a lot of things I use in pediatrics, to be honest. But again, individual data for rare disorders, we've really learned the power of the individual patient in collecting data at baseline, but it has to be very carefully, objectively collected. Many of you do keep meticulous notes. And if you think it works for your child, we trust that to a certain extent, but just remember that there are many examples now in rare diseases where things that were thought to be helpful turned out to be harmful or not working when they ultimately were tested. And I'm just going to give you a brief example of that with SMA. I know that valproic acid works in some individuals with SMA. It works via a direct upregulation of the SMN protein from a backup gene copy. We know it's highly variable among individual patients, but I saw amazing results, as good as the newly approved, nusinersen and these amazing therapies that really are proven in big trials. That being said, we could not prove it in a clinical trial that was placebo controlled. And that's because it only worked in the sub-analysis on the youngest patients. And it wasn't powered to do that, but under 5-year-old, but it has a lot of side effects. There were many reasons not to go on using it, but that negative clinical trial doesn't mean it didn't work in individual children. So any individual patient who has flunarizine and it seems to be working, that's fine, but we have to know how to adjust it as time goes on, because it can cause movement disorders as a side effect. And I cannot tell when I'm increasing the dose and a patient's getting oral dyskinesia or something like that, whether it's the flunarizine that's doing that or whether it's their disease. And that makes me really unhappy as a clinician.
Well, I know we have kids to pick up in the next room, but I want to give Bill Gerber the last question because he's been our tech support all weekend. So here you go, Bill. Tell your.
All right. This question is for all the doctors, but what do you call it? Dr. Yano specifically. Ready for this? Okay. So 20 years ago, I asked the doctors a question. Been here for 20 years. I still have the question in my pocket, right? Based on 20 years of all the information that you've learned, and I will have to say a little bit about your background, because I don't think everybody knows, but you did finish high school in about a week, in college in about a month, med school in about 3 months. Okay. So there's a lot of information in there, but he's got an amazing bio. If you ever read it, oh my goodness gracious. But anyways, based on all this information and based on you being prepared your whole entire life, there's no way that you came to this conference without the answer to this question. He does. What is the solution for AHC?
In 2 minutes or less.
I know you came prepared.
I feel like I'm going to sound like a politician. I don't like it. The solution is a team effort. What we've heard about finding, we need a lot of pieces. And I think people smarter than me and more knowledgeable will say this better, but we need to understand the biology of the disease. We need to understand what treatments may work better than others and which ones actually do work in the lab. We also need to be able to measure whether any of these treatments actually work. And so we need biomarkers and ways to put a number on whether a treatment is working or not, which is what the FDA and we all will need to decide whether these treatments are worth giving to children and people with AHC. So all of this is a massive community effort that will not be solved by any one person.
All right. Thank you very much, doctors. This was a great session. I'm sure there's other questions and people will grab you over the next half day for those, but thank you very much.